implementation science by truly co-designing with and for communities. So I want to start with an African proverb that really captures the essence of what we'll discuss today. So it says, if you want to go fast, go alone. If you want to go far, go together. Now, this African proverb really beautifully captures a fundamental tension in implementation science where, we often feel that pressure to move quickly, get the interventions out there, especially when the donors are already on our neck, right? To show us the results, scale up fast. And yes, we can really do move faster, when we work alone, when experts design in isolation. But here's the question. Are you really going far? Are your interventions sustainable? Are they acceptable? Are they really reaching those who need them the most? Or are you just going fast to nowhere? So before we explore these further, I would like to, clarify some foundational concepts, because implementation science and co-design might be a new territory for some of us here. And maybe you might have been doing it and you didn't know that you're actually co-designing or you're actually applying some of the principles of implementation science. So let's start with the basics. What is implementation science? So my beautiful prof has already, mentioned all of this. Perhaps I'll just re-echo what she had said. But simply put, in layman's language, implementation science is just science of putting an evidence that has shown to work, perhaps a trial that has been done, or even an efficacy or effectiveness study that has been done somewhere and shown to work. And then you're putting it into routine practice where people will daily use that intervention to improve health outcomes, okay? And we do know we have so many interventions out there that work. So for example, we know that vaccines prevent diseases. We know that certain treatments save lives. We know that some programs, right? Some programs can improve health outcome. But these evidence-based interventions often don't reach people who need them the most. So there's that gap. So reechoing what Prof had mentioned earlier. So there's that gap between what we know works and what actually do happen on the ground. So what implementation science does is that it bridges this gap by really understanding the contextual factors that influence whether the intervention will work or not. So contextual factors could mean social structures, it could mean cultural norms, it could mean systems and resources in place that can actually, play a role on whether your intervention can work or not. And then tailoring those evidence-based interventions to fit those contexts so that they can actually work in real-world setting. And this is where communities come in. But when I say communities, what do I mean exactly, right? So in implementation science, communities are the people for whom and with whom interventions are designed and implemented. So they could be people living in the same geographic area, right? It could be people with shared norms, beliefs, culture. It could be people with common interest and goal. And it could be organizational, so people working together. It could be healthcare workers, it could be people, say for example, the Lagos State Ministry of Health, program managers there. It could be bankers, it could be mental health program managers, okay? And what really makes them a community is that they share the same context, experiences, and often face the common issues together. And these people know what will work and will not work in their context. So let me tell you two stories that really illustrate why this really matters so much in implementation science. So pardon me that I'll be using a lot of vaccination examples, but this can be employed anywhere else. So imagine a well-funded vaccination intervention, designed by experts in capital city. It could be in Abuja, it could be in Lagos, right? Beautiful protocols, evidence-based strategies, you roll out quickly. Within months, communities don't show up, the intervention dies. Now imagine that same intervention, but this time, the team spends time, months, really listening to the communities, trying to understand barriers, developing, testing, tailor strategies. It might take longer to launch, no doubt, but when it comes, community leaders or communities champion it, the uptake increases, years later, it's still running without that external funding. So what made the difference? So the second team understood the communities, they understood the communities had to be the part of the intervention, not just recipients of the intervention. But unfortunately, most of our field today has been trained in this first approach, which is the problem. And that is why we really need to rethink how we approach implementation science. Let's start by examining the traditional model most of us has been trained in. So this is what the traditional model looks like. So you have your experts, your researchers, right? Take the evidence that has shown to work, and then, design an intervention. They develop the strategies, the protocols, they do the training, they do the implementation, and then they deliver to the intervention. So notice the flow. You see, it's a top-down approach. So from those who have that technical knowledge, right, of the intervention to those who need the intervention, which is the community. And the community role here is basically to receive the intervention, to comply, right, if they choose to participate. So on paper, this makes sense. I mean, evidence has shown this works, the intervention works. Oh, they look at the team composition, the researchers, oh, they have the expertise. Yeah, it should work. But here's what exactly happens when we implement it this way. So there is the low uptake, right? Communities don't engage in the way you expect them to, right? Even when your beautiful intervention has shown to work during the trial, it will fail in the real world setting because they don't fit the local context, the culture, the social structures, in fact, the real world challenges. And as soon as that funding ends, it collapses because there's no community ownership to really sustain them. Then there's the issues of inequity, right? It fails to reach the very people who need them the most. And the sad and most common assumption is that if we maintain fidelity, so stick to the protocol, this is the protocol you should follow for this intervention will work, we can avoid this. But this assumes that contexts are the same, and we all know that contexts are not the same. So what's the real cost of this traditional approach that most people, implemented an intervention with? So there's the wasted resources. So millions of dollars spent on interventions that don't achieve their goal. Then there's the missed opportunities. So you have the time and efforts that you would have spent on, approaches that would really work, you didn't. And then when interventions fail to reach the marginalized population, that's people who need this intervention the most, or worse, they even widen that gap. And perhaps the most damaging one is the eroded trust, right? Where communities that have been, subject of failed intervention. So it gets to a point sometimes when you get to a new facility, they're already fed up, right? Failed interventions, they become really skeptical of anything new you want to bring in. So clearly, we really do need a different approach. And this brings us to that paradigm shift that's gaining momentum in our field today. So recently, I think earlier this year, the Lancet Global Health published a beautiful editorial that really challenges us to rethink implementation science. So they said, if context is the king of implementation, people-centered adaptation is the queen. So what this essentially means is that context is not enough, right? Communities must really lead that adaptation of interventions to fit their realities. Now, there's a real risk here, right? So in all our implementation efforts and when we do all the work that we do, we face what we call the scale-up penalty. What does that mean? So this is where we have that diminished effectiveness. We often see when an intervention moves from a controlled research setting to real-world delivery. So traditionally, we would assume that once you maintain high fidelity, you would avoid this penalty. But this assumption has been challenged, especially when you're dealing with variable contexts, diverse populations, multiple actors in play and the likes. But there's a very bold recommendation from this editorial that I really love so much. So they said, when we do not have enough knowledge to perfectly reconcile adaptation and fidelity, we should not sacrifice people-centered adaptation to avoid the scale-up penalty. So in other words, what they're saying is that when you're in doubt, trust communities, center people over protocols. Because centering people can actually lead to what they call a scale-up reward, right? Scale-up reward where you're going to yield exceptional adaptations that are more effective than you originally planned. Okay, so think about that. Instead of diminished effectiveness, we can actually achieve enhanced effectiveness through community-led adaptation. And what does this look in practice? So what principles really is out there. With implementation science, we have a lot of frameworks and tools and models. We call it the TMFs. So there's models, the framework, and the theories to work with, right? So I'll be sharing an evidence-based framework with over 20 years of research that can be used in this setting. And that framework is the community-based participatory research, which is a collaborative approach that actively involves community members in the research process, making them true partners in that process. And this community-based participatory research has 8 core principles to effectively engage communities as partners. So we have the first one being to recognize communities as a unit of identity with their own unique features and context, building on existing resources that they do have, and then facilitate collaborative and equitable partnerships in all phases, integrate knowledge and action for the mutual benefit of all the partners involved, promote a collaborative co-learning and empowering process, making sure they attend to social inequities, involving a cyclical or a continuous and iterative process, disseminate findings and knowledge gained to all partners, and address health from both positive and ecological perspective. But for our time today, I'm going to focus on 5 of these principles. So the very first one being, facilitating collaborative, equitable partnership in all phases of the research process. And this principle really emphasizes the active engagement of communities in all phases, not just your data collection, not just your implementation, but from the very beginning, from identifying your research question through to the design, through to the implementation, as well as the dissemination and evaluation. And the partnership should also be equitable. So it's not just collaboration where, researchers lead and communities will just follow or maybe assist. It's a partnership where the power is genuinely achieved. And what does this look like? So it means communities actually helping in defining the questions, co-creating your research questions, defining the problems, co-creating your research questions, participating in designing the intervention, and even involved in interpreting the results and deciding how those findings would actually address their community concerns. But partnership actually requires the right foundation, and that brings us to the second principle that I've mentioned now, which is the principle of building on strengths and resources within the community. Now, with the traditional approach, what they often do is that, so when they get to a community, so remember, community does not have to be geographic. So it could be, like I mentioned before, it could be people who shared beliefs, people working together, people who shared goals, okay? So they often get there, and what they do is they just catalog what those communities lack. So they'll say, oh, these people, they don't have the resources, they don't have the knowledge, they don't have the capacity to do this work. But what community-based participatory approach does is that it flips this. So it starts asking questions like, what assets, what strengths, right? What resources already exist in this community that we can leverage, right? Because every community do have existing social networks. So they have women groups. If it's in the PSC, that's primary healthcare centers, they have the ward development committees, they have hospital committees. They have groups that you can actually work with that are trusted. So they also have the local knowledge of what works for them and what will not work for them. They have existing communication channels. They have cultural practices. They have leaders, both formal and informal. They actually do have experiences of how to solve their problems, even before you came with your research. So when you build on these existing strengths, rather than actually importing external solutions, our solutions are more likely to be accepted, sustained, and even scaled. So for example, rather than creating entirely a new communication system, we might actually leverage existing community gatherings, trusted messengers, the town announcers, which are most common, right, way of disseminating messages in a traditional way. Also, rather than assuming that communities lack capacity, we can actually identify, capacity that really exists in that community and build from there. So I'll give you a typical example. Instead of you actually, maybe sending maybe a program officer or a research associate to the community to go and do mobilization for you, you'll be so surprised that there's someone in that community. The person necessarily doesn't have to be a community leader, right, or traditional or a chief, but people are so drawn to him or her, right? And the person has that capacity to just pull people for you. So your job is to actually identify that kind of individual and bring them on board and build their strengths. And when you're building on that strength, it's just you're being strategic. So it really makes your interventions more feasible and sustainable. But again, recognizing strength is still not enough if we don't change the learning dynamic. And that takes us to the third principle, right? So let me unpack this. The third principle is more like promoting a co-learning and empowering, process that really attends to social inequities. So first is the co-learning. And the co-learning needs to flow both ways. Okay, so where the researchers bring in, their technical expertise and knowledge about evidence-based intervention, and then the communities needs to also share the contextual knowledge. So they have the lived experience, they have the practical wisdom. Okay. And then the second is the empowerment bit. So where you're actually building community capacity, not just to implement the intervention. So, because at the end of the day, you want, when your project ends, communities should have gained new skills, knowledge, and even confidence to address future health challenges, right, on their own. The third one, which is actually very critical, is attending to social inequities. Now, with community-based participatory research, right, you don't just pretend that there's no power imbalances, because they really do exist. So you need to acknowledge them and work to address them. And all of this actually means, compensating community members fairly, training communities in the research process, and even when it comes to the writing bits, developing those different knowledge products, your reports, your policy briefs, your blogs, your manuscripts, they should also share authorships on all of that. And also ensuring that the communities can actually veto decisions they disagree with. And the goal here is actually empowerment, where we shift power to communities, not just working with them while maintaining control. Now, for all of this to work, we need to deeply understand the community context. And that's the fourth principle that really recognizes community as a unit of identity with unique culture and context. So the principle really says that communities are not just geographic locations, like I mentioned earlier. They're units of identity with shared, values, norms, history, collective experiences, way of communicating, and even making decisions. Now, what works in one community may not work in another, not because one is better, but because context really did differ. So, for example, the same intervention might need to be delivered differently in urban versus rural setting, or even adapted, for different cultural groups, or even modified based on existing infrastructure and resources in place at that time. So if we treat communities the same, that is applying that one-size-fits-all approach, interventions would fail or they don't even fit. Now recognizing community identity really means, understanding the specific cultural context before you even start designing an intervention, adapting your intervention to fit that context, and also respecting that, communities have the right to actually shape the interventions for their reality. So, and this is what we call the cultural adaptation, not just, superficial translations, but really deep contextual adaptations that is guided by the community themselves. And because context change, we can't anticipate everything. And that brings us to the fifth principle, right? Which is the best for me. And it involves that cyclical and iterative process that really builds, flexibility, and you're responding to the needs as community change, as community evolves. Now, with community-based participatory research, it is not linear, right? So where you do your research, you design, implement, and you're done. So it's cyclical. It involves, more research. You do your research, you learn, you design together, you test, you get feedback, you revise, you evaluate, you adapt. So it's a continuous process, right? And this principle says that we should expect to iterate. We should plan to adapt. You should, build in that flexibility from the start, because we can't anticipate every barrier or opportunity. So I don't know, Rachel, do I have any comments? I think I can't see comments, but feel free to stop me if you need my attention.
Sure, sure.
Okay.
No questions yet or
Oh,
comments.
okay.
So just
Okay,
carry on. I
awesome.
think everybody is listening attentively.
Okay. So essentially, we can't anticipate every barrier or opportunity because community needs and context really evolve. So, but what we learn during implementation should really shape what we do next. So in practice, this actually means testing your interventions with community. So one principle I usually do is at least I give 2 weeks or 1 month pilot testing of interventions before the full deployment. So you can get those early, adoption and questions answered, implementation answered, and then you refine better. Okay. Then getting feedback, and revising multiple times. So there are always structures that you can actually leverage in every community, even in facilities. They have some departmental meetings that they do have. It's continuous. It has been there before you came, right? So how do you leverage that? Always give feedback to the community and also revise multiple times. And then building in that mechanism for continuous learning and adaptation, right, throughout your implementation. And then also being willing to change course, right? Because at the end of the day, you want to improve outcomes or health outcomes. So you should be willing to change course based on what you're discovering as you go. So these are the 5 community-based participatory research principles for people-centered implementation. Now, this might sound theoretical, might sound abstract, but I'm going to show you an example of how all these principles came together in one example. So using a case study from the IRIS study, so the Immunization Reminder and Information SMS system. So this was an intervention that was implemented in Kebbi State, Northern Nigeria. So I chose this particular, although this is one of my favorite projects to usually use for this, but I chose this particular case study because it beautifully illustrates these five community-based participatory principle that I just mentioned. So as I tell this story, I really want you to watch out for those 5 principles in action. So you will see how these principles transform what could have been a failed intervention into a successful one. So let's start with the problem first. So when we started this project in 2018, 2019, so Kebbi State had one of the lowest immunization rates in Nigeria at the time, and only 11% of children were vaccinated. So at the time, the most reported reason for non-vaccination was lack of knowledge about where to get vaccinated, when to get vaccinated, and where to get vaccinated, right? So we had an idea to use SMS to remind parents of their children's vaccination schedule, so which is what we called the individualized broadcast. And then to provide the general public information about the benefit of vaccination, which we call the generalized broadcast. Simple, right? I mean, evidence has shown that reminders work. There's been Cochrane reviews that have shown that it works, but we did something different. So instead of just implementing the intervention, we asked, will this actually work in Kebbi State? Although this is what we're funded for, this project was funded by Gates Foundation to International Vaccine Access Center at Johns Hopkins School of Public Health. And they wanted to know whether SMS reminders can work in a very low resource setting. And if you know Nigeria very well, you know that Kebbi State is a rural state. So they really wanted that low resource setting, whether to know, can it work not in Nigeria, but in this particular specific context? So rather than assuming we knew the answer, we committed to a people-centered approach. So we listened first, you co-design later. So we conducted a formative research, right? So this is where we, did the research to really understand the context and to also design our intervention. So we did interviews, focus group discussion with over 100 people, and majority of them were community members, like about 90% of them. And then we asked questions about the barriers to immunization, the social norms, the phone use patterns, because this is an SMS project intervention, the message preferences. So we listened deeply. So based on what we've found, we also co-developed messages, right, in local languages, with communities and the health communication officers at the Kebbi State Primary Healthcare Development Agency. Okay, so we found many challenges. Most community members do not own phones. Even those that own phones, they cannot even read, right, due to the low literacy level. They only know where to receive phones and, where to make calls. And again, preferences, there were varied preferences, and there was also the issues of lack of awareness, registering and all of that. Now, if you're to go with the traditional approach, that's the expert-driven approach, would have abandoned SMS entirely. I mean, these people do not own phones, they can't read, right? It won't work here. Let's look for a different intervention. Or you can actually push ahead, maybe just modify it slightly and hope for the best. But we chose a people-centered path. So what we did was we brought these challenges back to the communities, and we asked, hey, how can we make this work, right, in your community? This is how we've initially designed the intervention to send it to the general public and to personalize, but the data we're getting from the formative research is telling us differently. So what happened next was the magic of co-design. So where communities didn't just identify these problems, they now started proposing solutions. So for the low phone ownership issues, communities said that we can actually use proxies. So proxies are like their friends, their relatives, even their husbands that own phones, right? And then that we should also send to the community leaders, right? Their menguas, their district heads, and the secretaries to the district heads as well. And the WDC members, as the Ward Development Committee members, and some opinion members in the community. So we should send them those messages. And they already have, trusted communication channels. And for them, it was their town announcers as well as, so there's a meeting that usually happens after Friday mosque, so that we can send those messages, okay? And then the issues about barriers to vaccination, where we also, beyond the misconceptions, we also have husband's disapproval, cultural issues, and all of that. Because we employed a community-based participatory approach, we do recognize these power dynamics. So we adapted and included a targeted broadcast messages. So messages targeted to community leaders, including even husbands as well, right? Mentioning the benefits of vaccination, and when the facilities in their communities will be holding sessions. Then there was the issue around the messaging, because the messaging we developed, it was slightly over 80, and we had to test the messages. We wanted to make sure, it resonates well with the community. So communities identified the messages to be unclear, culturally inappropriate, and unlikely to motivate action. So they completely reshaped the message content, right? So including more messaging on how to dispel misconceptions and the implications of the implications of not getting vaccinated, just to motivate people to get vaccinated. And we tested this across, and at the end of the day, we got 33 messages out of the 80-something. Again, with the varied responses, communities actually specified when to, send messages, right? Some said there were some messages that were sent early in the morning before the Friday prayers, and for personalized reminder, it was a day before the immunization session. So communities really knew, when people would be most receptive. They told us the language to send the messages, the frequency, and most importantly, the multiple delivery channels. So what was the transformation? So the original design was simple. SMS goes to the general public about, vaccination, and a prompt for them to opt in. If they want to receive more messages, they should opt in to receive more messages. And then to the individualized, the parents, what we call the individualized SMS, reminding them when to get vaccinated. But when we use the community-informed or centered design, so it now became SMS goes to the general public as well as the parents, and then we had that by the targeted broadcast to community members. So you can see that it flows offline, okay, and then flows offline through the town announcers, right? So the community leaders, the key individuals get the messages, send it and channel it through their existing communication channels in the community. That's the town announcers, the religious gatherings, and all of that. The healthcare workers also supported SMS reminder system. And I forgot to actually point out something that happened then. So there was also difficulty to, communities do not know how to even register. Even among the educated one, they felt it was too complex. So we had to even simplify the messages. And when we're implementing the IRIS intervention, then NPHC, that's National Primary Healthcare Development Agency, was implementing the community engagement strategy. And one of the components of the community engagement strategy at the time was community leaders to do line listing, right? Community leaders and the healthcare workers in that sector, like the healthcare workers covering their settlements to do line listing. So line listing essentially is going from one household to the other to identify, vaccine eligible children. So because our intervention, we engaged communities, not only geographical communities, but if communities, the Kebbi State Primary Healthcare Development Agency, so they were aware of this intervention. They've been on board from day one. So in the line listing register, there was a column for the SMS reminder. So for the activities, we're collecting phone numbers from each household, and healthcare workers were actually also helping, parents to do the registration. Okay. Now, phone owners also became conduits to community dissemination mechanisms. And of course, the existing trusted network became our implementation infrastructure. So notice, how this intervention didn't get simpler through community input, but it got really richer and more, embedded in the community. Now, all the community engagement activities we did, all the adaptation, they didn't really make IRIS less feasible. They really made it more feasible, culturally appropriate, sustainable, and even, made us reach more people easily. And that's because communities solved the problems we couldn't solve. They identified implementation pathways we could not have seen. So I'm going to pause here for a minute, 2 or 3. And I'd like to hear from the participants. So pardon me if you've seen my head move this way, because I can't see chats. So I have another device on here. So I'll be looking out for text to see. So just take a minute and tell me what really surprised you most about how community input really changed IRIS. Can you just drop a chat or two? I'd like to read your thoughts. What really surprised you the most? I haven't heard how we're implementing this intervention and how communities made an input into this intervention. Can you tell me what surprised you most about how community input changed the design of the IRIS intervention? So I'll be on the lookout for the chats.
I'm also checking the chat as well.
Awesome. Oh, I have you, Rachel. I might
Yes.
as well turn this off. Okay.
I'm checking
So
the
just
chat.
yeah. What surprised you the most?
I think maybe I can start talking before
Okay.
people drop their comments. Whilst you were given the overview of how to involve communities, I was just thinking that I'll ask that question at the end, or you sort of answered my question. I was wondering the literacy level of the community members, and you sort of touched on it when you were trying to propose ways, and that's why you're doing informative research, okay, to figure out ways to disseminate, like we know, an SMS in a low income setting as ours. Not everybody owns a phone. So the literacy level, how were the community able to adapt? How were they able to accept? You sort of answered the question, but how were they able to like take it in? How were they also able to like give their own buy-in or their own understanding of the whole intervention? So it was just something that was running through my mind. And for this particular study, it's showing that they were very interested to improve the vaccination status in the community, and that is quite an insightful thing for for a community, because this is something they're not used to. They always leave it to the healthcare workers or the people who are learned and stuff. But you can see, like, from the community leaders trying to give their own beats to improve. So it was quite insightful. I'm checking to see if there are any comments. Okay, no comments yet. Why is everybody quiet? Does everybody understand?
Or am I speaking too fast?
Oh, really? I do apologize. I hope it's not the network.
Oh,
But did you get what I said?
yes, I heard. Okay, I think I'm seeing some chats coming.
Yeah.
Okay. So I see involvement of stakeholders. Good. We engage them. So from the day one, we ask questions about who needs to be at the table. Who do we need to approach first in the community? Yes. Okay. Oh, okay. Pardon me. Okay. The chat was locked before. Okay. Okay.
Okay, Chisom, they said maybe
Yes.
you have to slow it down. That
Okay, slow it down. Okay, I'll do. Thank you.
All right.
Okay. Okay.
Someone said it's a quite
I was wondering what
wonderful
strategies help build
approach.
trust with communities. Exactly. So maybe I'll quickly respond to a comment here from Ndubisi quickly, where he asked, so what were the strategies that help build trust? So we worked with like I mentioned, worked with the community leaders, right? So we engaged them, sensitized them, got everyone that matters to the table, introduced the intervention, told them how we have initially planned, and they shared concern about, where they think we should make some adaptation. And this is where we brought in that targeted broadcast. So for example, even after we've done our surveys and our interviews, that's really shown that people do not own phones, people do not read messages. So they told us, okay, when you send it to us, right, the community list, we are able to disseminate it. We have different channels. We have these community gatherings, and we have these meetings we usually have every Friday after mocks. We can disseminate those messages doing that.
Okay, so we have
Using
a
that. So
comment.
the community
Okay.
gatherings. So there's a couple of comments coming in, and
Yeah.
yes. Okay, so exactly. So now let's talk about what this transformation actually achieved. Okay. So I'm not presenting the quant study here, but I'll be presenting the quali findings where we assess the impact of this intervention using the REAIM framework. So REAIM is an implementation science framework that you can actually use to evaluate your intervention. So it stands for reach, effectiveness, adoption, implementation, maintenance. Now, besides the intervention actually being, implementable and, having that high acceptability, because I mean, as you can see, the context really shaped it. Communities championed it, where the community leaders were, used their time and answer to disseminate the messages, and even during community gatherings and the meetings they usually have every Friday after mocks, they were able to disseminate those messages. Okay. The intervention also reached everyone equitably. So even as a reminder, right, or about the benefit of vaccination. And at some point in time in the course of the intervention, we used it to send messages on COVID-19. So in terms of effectiveness, it reminded caregivers, especially those who were busy and forgot their child vaccination. It increased awareness and knowledge about vaccination, and it also triggered discussions about immunization. So I'm going to just quickly read one chat from a father here. He said, I was not aware that those diseases could be cured, but because of the Tunanta Dani message, and yes, the community also came up with an acronym for the intervention. Tunanta Dani meaning remind me in Hausa. So he said, but because of Tunanta Dani messages, I let her know, right? So there was that increased awareness about and knowledge about vaccination. Then in terms of adoption, like I mentioned, we engaged the Kebbi State Primary Healthcare Development Agency from the start. So they incorporated IRIS, that's our SMS reminder intervention, as part of the activities that they assessed, right, during the RI, routine immunization supportive supervision, and even they also encouraged communities to, register. And even when they go to facility, doing those RISS, so routine immunization supportive supervision visits, when they go to communities and they meet new healthcare workers, they also educate and train the community how to do the SMS and reminder registration. And then, so our intervention ended in May 2020. And even after the intervention ended in May, NCDC used the IRIS application, right, to send COVID-19 messages between June and July. But there were also deeper transformation that happened. So there was a capacity building. So communities now learned about mHealth technology. So they know that you can actually use phone, right, to, share or raise awareness about an intervention. So they built the skills in health communication because the community leaders were also able to, share the messages during those gatherings. So this knowledge stays in the community even after the intervention has ended. So there was also the empowerment piece, right, where community structures were strengthened. So leaders gained, experience in health promotion, and this capacity built for any future health interventions that might come in that setting. Trust was also enhanced, between the health system and the community. So the communities also saw how the inputs, right? We came first, we heard from them, we went back and we designed. So they saw that all the feedback they gave us from even how to simplify the registration, even how to, instead of having just the general and personalized, we incorporated the targeted broadcast to the community leaders themselves. So they really saw that input. They saw that their input really mattered and that they were true partners. And last but not the least, which is the scalability part, where we saw that you can see that the process became scalable, not just the intervention. So SMS has been used, and other contexts can actually replicate this co-design process, for their own. Now remember the scale-up penalty that I mentioned before, where there's diminished effectiveness, especially when an intervention moves from where it's, it has shown to work in a control setting into a real world setting. We discussed before. So this is how it happened with the IRIS project. That's the SMS reminder project. So instead of a scale-up penalty, right, where that effectiveness decreased, IRIS achieved a scale-up reward, by yielding exceptional adaptation. So you can see that we had a targeted broadcast to community leaders that were more effective than what we originally planned. Because if we had, the original plan was just to send to the general public, but we know that most people cannot read, right? Some people might not own phones. So even those, some of them cannot read messages. So, but because we incorporated, right, that targeted broadcast to community leaders, volunteers, even the healthcare workers. So it became more effective than what we originally planned. And all of this, all because we centered people in the implementation. So the intervention were able to reach more people. And we also built capacity in ways that original design never could have achieved. Now, you might be thinking that this is just one case study about SMS, immunization, but the lessons are really universal, right? And you can actually apply these principles across all types of health intervention. So I have used it for mental health issues, currently using it for maternal health programs. And that Lancet paper that I just showed you also showed how you can actually co-design, working in all of these, including even chronic disease management. They also, you can also apply this beyond health entirely. I'm using it also in an education intervention among internally displaced persons. So you can use it in agriculture, you can use it in climate adaptation, any implementation challenge ever, okay? So what really matters is the process of your engagement. It does matter as much as what you're implementing. So how you really build determines whether it can stand or not. And communities hold that essential knowledge that no amount of technical expertise you have can replace. So what are the actionable steps one can really take to bring this people-centered design into their own implementation work? So I have put together these in three phases. So pre-intervention, that's before your intervention, during the intervention, and after your intervention. So pre-intervention, you need to do what we call a stakeholder mapping, right? There's a lot of tools out there that can really help us in doing the stakeholder mapping. We'll have the RISI tool and majority of them out there. So, but the key question is you need to start asking from the onset, right? Not just what intervention do you need, but with whom should you be designing the intervention with? Who needs to be at the table from day one? And the most affected people represented. So you need to engage these individuals that you've mapped, not only to get their buy-in, but to have an intervention that is really owned and driven by the community. And the most important part for me here is the formative research. It cannot be overemphasized, right? You need to really understand the context before you start any design at all. And then you need to, even when you've understood the context, you need to now design and co-design it with the communities because they know what works for them. Let communities propose solutions. They will propose solutions you never really imagined. And when they're doing that, be humble and open enough, right, to hear them out. Now, once you're in the intervention phase, let communities lead where possible. So, for example, with the IRIS here that I shared, community leaders disseminated these messages using town announcers and at community and religious gatherings. So again, there's also the testing and the iteration that happens. So always assume that your first design is not the final one. So keep listening, you keep monitoring, engaging the community, using existing platforms throughout that implementation, not just at the beginning, okay? Create or leverage, I would prefer to leverage mechanisms because what I've seen that's worked for me in the last 14 years has been to leverage exist. There's always something in the community that you can work with, always something. So again, your job is to identify that mechanism. They have a mechanism they use to disseminate something they used to work with. Leverage those mechanisms to also give feedback and receive feedback from the community. Also maintain flexibility, for that continuous adaptation because context changes, community needs evolve, and your intervention should be able to adapt to these real world changes as they happen. And please do not forget to document, which is my favorite part. So document what happens, what adaptation, what worked, what didn't work, what make it work, why did you do the changes in the first place, right? Who informed that, what informed that changes, who made those decisions, right? And even when you've done that, always disseminate your findings. So sometimes what usually happen, when I see happen, when I go for dissemination workshop is, I don't see the communities that actually co-created or participated in the intervention in the dissemination meeting. So you see more of high level people in dissemination workshop, and that's a practice we really need to change. So we need to also be sharing those findings with the communities because they can also know how best they can actually start using that going forward, even after your intervention has ended. Like I said before, document because you're also giving other settings an opportunity to replicate your process, not really your intervention, but the process at which you were able to, contextually adapt or develop your intervention and also learn from your practice. So before I close, I want to hear from you in a minute, 2 or 3, or even up to 4 or 5 minutes, right? Some of the things I've said here, you've done it before. Maybe you didn't know that you were applying some community-based participatory principles in the work that you've done. But I want to believe that from my explanation so far, you might have seen 1 or 2 things that, I didn't know that what I did before was actually a community or people-centered approach. Okay, so I'd like to hear from you. What barriers do you face if you're currently doing an intervention now? Or have you faced in implementing people-centered design? So I'll be happy to hear your thoughts. So don't mind me that I'm always asking you, we're in a co-learning environment. So you're not only learning from me, I also want to hear from you as well, right? What barrier do you face or have you faced in implementing people-centered design in your work?
Okay, we have one barrier is definitely language barrier.
Yes.
That's from one of them.
Okay.
The issue of trust,
Mm-hmm.
language barrier, issue of trust, the issue of culture, definitely.
Mm-hmm.
I can attest to that. Even on the Ivan trial, we had a lot of culture issues, having to introduce intravenous iron in Kano and even Lagos states, most especially in the northern states.
Good.
Mm, The importance of co-designing and co-creating with the community cannot be overemphasized. Also, quite key in documenting. Yes, I agree. Documenting is very
Okay.
key.
Okay.
Yes, what is documented is definitely not done. Misconceptions, language already
Mm-hmm.
mentioned, no
Mm-hmm.
interest from the key stakeholders.
Mm-hmm.
Yes, that's literacy. It boils down to literacy, the community not understanding the intervention you want to give them, beliefs
Mm-hmm.
very important.
So these are
Entitlement
mm-hmm. Go ahead. Mm-hmm.
mentality,
Mm-hmm.
entitlement mentality from the people,
Mm-hmm.
literacy, like I mentioned, cultural
Mm-hmm.
beliefs, myth, wrong target of beneficiaries, understanding importance of the intervention, community
Mm-hmm.
expectations. So I guess everybody has had that
Well,
same
it has exactly,
issues.
and these are real barriers, right? These are
Exactly.
real
Yeah.
barriers, and that's exactly why we really need to keep advocating for people-centered approach. So let me use the language barrier for example. Each context has a language they speak, right? So
Mhm.
it's about identifying that common language they speak, and you disseminate that information, using that language. Like for example, in the KB project, in the SMS project, it was Hausa and I think one other language, if I can remember clearly. My Hausa is terrible. But it was disseminated in that local language. So identify, and we know that in northern Nigeria, for most of us have done intervention, they have different language, just like in Igbo, right? In the East, our Igbo are different across different states. So it's about
Yeah.
identifying the particular language that is being spoken in that context and working with that. And again, when you work with the communities, right, these people really do respect their community leaders. They trust their community leaders.
Exactly.
In fact, there was the first project that really opened my eye into, implementation science, which is the Vaccine Indicator Reminder Bank intervention, right? That was done in 2016, 2017. That project, so it was a project that was a band that was designed in Pakistan and brought into Nigeria. They wanted to test if it's acceptable. The communities they didn't believe us because we said the band was safe. They only accepted the intervention because the community leaders were involved in the intervention. Right. So that takes me back to that, and that takes me back to that first point I mentioned is identify who are the right people you should speak to. Okay. Who are the right people I should be speaking to, I should be designing with, right? That can help make things work. So let me bring us back to where we started. Okay. Remember, we opened with this proverb that if we want to go fast, go alone. If you want to go far, go together. And now, having talked you through the foundations of implementation science, the community-based participatory research framework, the IRIS case study, the practical steps, I hope it has resonated differently, and we've really seen what going alone looks like. So there's wasted efforts, the missed opportunities, the failed interventions, the eroded trust. We've also seen what going together achieves, right? So there's that sustainable solutions, community ownership, and the scale-up reward that I mentioned previously. So every one of us in implementation science, we face this choice. We can continue designing in isolation. You skip the formative work, the co-creation, the implementation, you roll out quickly, and you're done, right? But we know where that leads us. Or we can actually embrace people-centered design to really achieve sustainable impact. And for me, this is implementation science at its best, right? You are not just deploying intervention, but you're transforming systems and also building sustainable future together, where we share control and we're also also changed as researchers, by that process, because that's not the only way to create change that lasts, right? That reaches everyone, that truly, because that's the only way to create a change that will last, that will reach everyone, and will truly address the root cause of health inequities. So as the Lancet paper declared, people-centered adaptation should be crowned the queen of implementation. I would like to humbly add that it deserves that central role in everything we do in implementation science. So the choice is ours. We either go fast alone or we can go far together. And I will say, let's go far together. Thank you so, so much for your time and for listening and for the engagement so far. And I'll be happy to take your questions. Thank you.
Thank you so much, Chisom. This was, wow, mind-blowing. I've really learned a lot, and it cast my mind back to when we were doing the formative part for the IVON trial and how we had to seek the opinion of the community leaders, the matriarchs, the male partners, in the conception of the intervention for intravenous iron, like to treat iron deficiency anemia in pregnant women. We had to first speak to them to get their views and their understanding. And it really shows that, yes, the community is indeed very important in making sure that these interventions are scaled up properly and they are also implemented as at when you. There are a lot of questions. I'm going to go on quickly to read them so that we can take them. So the first I have on my list here is how can transformation implementation science? I'm sure if I read some of them, you must have answered. So we could just a few seconds of repeat answer. So how can transformation implementation science integrate relational dimensions such as trust into its core framework? That's the first question.
Okay, I didn't get that question, but let me
check
it's on the Q&A.
Q&A, yes.
Okay.
The Q&A, the very first question from Patrick.
Okay.
Can you see it? Yeah.
Okay. So do you want me to answer that one after the other?
Yes, please. Yes, please.
Okay, so how can transformation implementation science, I don't think I got that, but okay. How can transforming maybe practice in implementation science, I believe that's what he meant, right? Integrate relational dimensions as trust into its core framework. So the first thing first, how you can actually establish that is by, again, identifying the key individuals that needs to be there. They need to also see that intervention that's also addressing their needs. Let me still use this IRIS intervention as an example. So at the health systems level, right, that's the Kebbi State Primary Healthcare Development Agency. They adopted IRIS, that's SMS reminder intervention, because at the time, right, they were doing everything to improve their immunization coverage. And evidence has shown that SMS reminders work. So they were ready to adopt that. Okay. And there were, like I mentioned before, National Primary Healthcare Development Agency at the time were doing an intervention, a community engagement strategy intervention, and it was easy to embed IRIS into that. So we were able to establish that trust that, hey, this thing can actually work, right? And they saw that they trusted that it is going to be feasible and it can actually work in reminding them, right? I mean, in reminding the communities. Now, let's take it to the community level. So how were we able to establish that trust? The communities, they did value. In fact, I remember one district head actually telling us that he liked how we respected him, that some people will come here, they'll just meet with the healthcare workers and they'll just be working with the healthcare workers on their own. So we actually had a particular sensitization meeting strictly for district heads, right? So we engaged them, we sensitized them about the project. So at a point in time, they also helped us in developing the posters. So permit me to also use the VRI band intervention study to also illustrate this further. With the VRI band, when we brought it in, it was strange. I mean, it's a band that has been designed to be worn on the ankle, right? It looked strange to the community, but because we were able to establish that trust with the community, the community leaders themselves nominated the traditional birth attendants we worked with. They nominated them. So we gave them a criteria and said, we want these people, someone that has been involved in health interventions, someone that, is well known to support delivery and all of that. Using that criteria, they gave us list, and then we interviewed and took, engaged those we needed to engage. So that also built that trust for the community. Even the community leaders, even when the band was the red ink on the band was rumored to be the blood of the infant, before our team could come from, so this study was done in Bunza. Before we left bringing KB to Bunza, the community leader had already called a meeting without us knowing, right? And there, they brought a band, and they activated the band in front of the community, and they saw the red ink, pop out, okay? And it was clear. So these are all the ways you can actually engage the different levels and sectors and individuals in this to establish that trust. I hope that answers your question, Patrick.
I believe it did. I believe it did. So let's just move on quickly to the next question. The next ones are comments, but the next question I see here is, what about the ethical? Yes, he says thank you. What about the ethical challenges in regards to privacy and confidentiality when it comes to routine immunization and not immunization during campaigns? She was yeah.
That's a very, I don't know the name, but that's a very brilliant.
This from Chidera, yeah.
Oh, Chidera. So that's a very brilliant question, Chidera. I mean, there's always been that issue about ethics concern and all of that. So with the IRIS intervention, of course, before we started collecting the phone numbers, we sought for their consent, right, to get the phone numbers so that we're able to send those messages. And we do have the information at the back end. Of course, we shared how we're not going to disclose their personal information beyond the split team, and when we're going to be disposing of their information after the intervention. So all those ethics considerations were put into the plan right from the point of registration. Okay, and of course, during vaccinations, the healthcare workers, they've already been trained on the key messages to deliver before before administering intervention, and of course, the consent was also obtained.
Okay, thank you very much, Chisom. So another question here we have from Lydia. So my question is mostly based on sustainability, which is one of the major principles of most interventions. We all know that. How was the communication, which is the SMS, sustained even after the end of the project? I think you mentioned that, because I have observed that once remuneration is involved, workers tend to withdraw once the funders have concluded the project. So
okay,
how are you?
So, yeah. Okay. So I think I mentioned slightly that even when the intervention ended, NCDC had actually used our intervention as well, right, to disseminate information. But you raise a very valid question, which is still a challenge till date. So the intervention with the IRIS intervention was just to pilot. We just wanted to test if that works, right? And of course, sometimes funders and donors do have their priorities, but I have another example to help illustrate how sustainability can work, right? So there was an intervention we did for, at Brooks Insight, we did for the, I think I have the QR code here somewhere. So maybe if you can scan that and we read about the intervention. So where we built the capacity of program managers, right, for tailored immunization program. And what we did first was that we embedded this, yes, right here, this intervention here. So we embedded the intervention within the FCT Primary Healthcare Development Agency. They initially had a training working group. So what we did was we revitalized, right, the training working group. We built capacity of the members of the training working groups on how you can do co-creation. So you design, you diagnose, you design, you pilot test, implement, and then you evaluate. Okay, so we built that capacity within them, and these individuals now went into the community, now trained the program, the LGA program, and that's local government area program managers, and the program and the healthcare workers, and also supervise the healthcare workers co-design strategies with the community. Now, as I speak to you today, the training working group are still in place and they are still employing that approach, right? For communities not to, before it's always that one-way message of, oh, we're going to be holding sessions today. But right now they're asking questions to understand, what are their needs? Why didn't they come? Coming up with very simple, good enough strategies. So if you have time, please do read this paper and you're going to see how these committees were able to come up with very simple strategies. In fact, one particular one in one of the communities I was co-designing with had this Operation Bring Vaccination. They call it Operation Bring Vaccination because it takes 3,000 naira, so 1,500 to and fro, right? 3,000 to and fro to go to the nearest facility to get vaccinated. And the issue was not vaccine hesitancy, so rejection or delay. It wasn't it. The issue was that the facility were too far. So in the course of co-creating, so they now decided to, instead of everyone just going individually, why don't they contribute that money and call the healthcare worker to come to the facility, right? Outreaches were not happening as planned because it was about an hour plus. I never knew that places like that existed in Abuja. And this thing is still happening till this. So very simple solutions. Sometimes some of the things we need don't really need that so much money. They're just very simple solutions that can actually work.
Exactly. That is very spot on. Yeah. So we're almost done. We just have like 2 questions to go. So this is another question in co-design processes. That's towards the end, Chisom, if you're looking for the questions. How do we balance what communities want with what is technically feasible and financially sustainable? And who ultimately decides where the line is drawn? Okay, so this question is quite lengthy. For context, a health program asks a community to co-design a mobile app for tracking maternal health. The community wants it to include video tutorials, real-time chat with doctors, and personalized alerts. While highly desirable, developing and maintaining all these features is costly and requires internet access that many families may not have. The team must decide which features to prioritize, sparking the question, how do we balance what the community wants with what is technically possible and financially sustainable?
Thank you so much. And thank you, Ndubisi, for that question. That's a brilliant one. I don't know, in the course of the IRIS intervention, I've explained that, and I'm happy to use another example, but maybe let me take you with IRIS, right? The foundation has funded us to do the generalized and the personalized, right? Now, going to the community, we know that even when you do generalized, some people cannot read SMS, okay? And some people also do not own phones. Now, what is technically feasible at the time is to have that bi-weekly targeted message. So you have now 3 layers instead of 2, 3 broadcasts instead of 2. So what we did was going back to the funders to say, so with this generalized, we can actually split this generalized. So it's always that difficult conversations to have, but unfortunately, you just have to have it, right? So how do we split this generalized in a way that you can send generalized to people that own messages and then also have the opportunity to still send to these key individuals that community has said we should send the messages to. So we're able to technically do that and it's still financially do that. And who ultimately decides where to draw the line? Unfortunately, funders play a role, right? But from experience, I would say 6 out of 10, they do always listen. When you come back to them, with hardcore evidence, I mean, facts speak for themselves. Because at the end of the day, they also want the intervention to work, okay? So always speaking with the facts to show this is what it is. How can we restructure? How can we work best with this? And also, again, also identifying there's a lot of health programs going on. The government is really investing strongly in health interventions. Identify what is happening in the facilities, in the state Ministry of Health. There are a lot of partners also doing things, when you bring them, from that initial start, when you bring everyone on the table, you get to learn who is doing what, that you can actually leverage and get your things done. I hope that answers your question, Ndubisi, and I'm happy to take this further if we're running out of time.
Okay. Thank you very much, Chisom. We're doing well, but we need to run. Okay, so from experience, Ma, please, can you share different ways community members can be compensated for their time in line with Principle 3? I think that's the third principle of the
Yes.
community that you spoke about.
Okay, how they can be compensated. So for example, I'll give you an example. There's a project that we're doing with the IDPs here. So what we did that, how you have a study advisory group at the beginning of your intervention. So we also had in quotes, our own study advisory group at the community that we call the Intervention Steering Committee in each of the IDP camps. So made up of the IDP chairman. IDP, I mean, is internally displaced persons. So IDP chairman, the PRO, public relations officer, the youth leader, the man there, and then also pastors, the woman leader. So they make up the IEC committee, that's an Intervention Steering Committee. So what we did that they were also helping us with the mobilization, okay, of all the participants we need to deliver our intervention with, and we compensate them for that. Right. And we also compensate them for their time. They were also they also co-deliver the session. So what do I mean? So in each class, you have the lead local facilitator, you have the study team, which is us observing the delivery of the intervention. And then we have the IC member in each of the classes also observing the intervention. So we also pay them for their expertise and time, for being part of that. So those are some of the things that we do to compensate them for their time in the work.
All right. Thank you so much. Okay. Patrick has a follow-up question, but let me just before I take that, let me take this one here. Could you please advise on the best way to approach a community where the key stakeholders have not approved an intervention program, despite the fact that the community members are interested in the project? The only way to secure approval to implement the project is that in that community is through those same stakeholders who currently do not support it. Okay, so this is so what do you think? The best way to
yeah, by the grace of God, I've seen it all, right? In fact,
yeah.
there's a particular, I don't know if my team is listening, I'm sure they know the story. So there's a particular project we wanted to do, and this man everybody was interested, and this man, you really need his approval to get this done. And there's one day when I met him, I had to go myself, and I listened in. So you have to also be an active listener. And if you're a qualitative researcher, one of the key skills you need to have is also listen carefully and actually try to read behind what anybody is saying. So essentially what the man wanted is, for any knowledge product that'll be coming out of this study, I want to be part of it. That was what he wanted. So it's about trying to understand, what does this person really want? In some cases, some of them want money. In some cases, some of them want recognition in something. In some cases, some of them want to have, key role in the study. Okay. So in some cases, I've even actually had made someone a co-investigator on a study. Right, a co-investigator on a study. I had to write back to the RIB, imputed the person and all of that. It's just about understanding what do they really want and see how you can fit it in. If it's the money bit, right, there's always that, compensation money for their time in the project. See how you can slot that person in. If it's the non-incentives, which is the recognition and all of that, if you're making presentations, involve him or her, have a slide for him or her. right, to present. And if you're writing, involve them in those writing piece. I hope that answers your question.
I believe it does. We've had one or two cases of that too in projects that happen at the center. And yes.
And please, if you have further questions, maybe because we're running out of, I don't know, I'm not looking at the time, but if we do, please feel free to reach out to me, and I'm happy to take this conversation further. Okay?
All right.
So let's connect.
Thank you very much. So I think just one more from Patrick. He said he carried out a similar project in Brazil with the Quilombola community, but this community faces issues of recognition by the Brazilian government. I fully agree with the inclusion criteria you mentioned, but in communities where it is difficult to nominate a representative, how do you address this challenge?
To nominate a representative. Every community do have, and sometimes there's that, power play of, some sort of hierarchy, right? It's just for you to identify the top hierarchy and then just work from there. Because sometimes people respect that top person or key leader. Okay, so we cannot come to the table and nominate. And if in some cases you just have to split roles. So I usually do have assistant self. I have focal person and assistant focal person in the community. Split the roles. And everyone is happy.
All right. Thank you so much. If we are here answering questions, we will not leave here today, but I believe everyone understood what has been taught today regarding community engagement and involving the community. And I personally want to thank you again, Chisom, for taking out time. I know how very, very busy you are, but taking out time to take us through this webinar was very insightful, even for us at CC and for the academic community at large. So thank you so much, Chisom. I have posted on the chat that if anybody has any questions, they can reach out to our emails on either the scan the barcode or the info.cctris@unilag.edu.ng. That is our emails. You can send your questions there if you have any more, and then we will pass it on to Chisom Mobijet and respond to you as soon as possible. And so we'll move on quickly to our closing remark because we have come to the end. You can still follow us on our various social media handles that the IT will post on the chat. And I'll hand it over to Professor Banke Thomas Adoragbemi, who will give us a closing remark. Over to you, Prof.
Thank you very much, Rachel. Chisom, I can't tell you how proud I am of you. I think you would all agree that we should be giving Chisom a very big round of applause. So I'm looking for those claps. I'm looking for those claps. Put up mine. Okay, Chisom, well done. That was a great talk, and it's really lovely that you're able to bring implementation research to life. I think that's what I sort of took from that. It was a great talk. I love the way you highlighted some very key things, and I think everyone has sort of I won't rehash all of them, but I think this whole thing on the sort of power of the community to be involved in this implementation is the big message, and how the experts come with their own ideas and it fails. And why engaging them from the very beginning is the way to go. So well done. It was a great presentation. I repeat one more time, and I think you deserve your Zobo for this one. We're very grateful to you for sharing your time and sharing your insights with everyone at CC At the peak of that presentation, I was counting over 120 something people on the call. So it was certainly well attended, and I'm sure a lot of people will be reaching out to you for follow-up questions going forward. Look, ultimately, as we move forward with implementing evidence-based interventions, as we call them, we are going to increasingly realize the importance of engaging with communities of different contexts if we want things to work. The money to implement these things is not plenty anymore. Global health budgets have shrunken significantly. So whatever monies we are spending, we have to be spending it right. And implementation research helps us to better understand the context for implementation, for us to be able to maximize those gains from the little money that we have. So please, I hope that now we have over 100 plus disciples that will speak the implementation research language, that would ask more questions about context, that will see the value in engaging with people locally and be able to maximize those gains from interventions that we implement. Thank you very much, and we hope you enjoy the rest of your day. Thank you, Rachel, also, and the team for putting this together. Great job. Well done. Bye, everyone.
Thank you. Thank you so much, Prof. Adura. Thank you, Chisom, once again. Thank you to our attendees and the whole CC3 team. We do appreciate you. Please follow, join us on our various CC3 handles to see our upcoming events and upcoming webinars for the end of the year. And we would love to see you all again sometime. Thank you all. Thank you, all those joining from Europe, US. We see you. Thank you all so much. Thank you, thank you, thank you, thank you. Thank you, Chisom. Thank you, CC3 team. Bye, everyone.